I'm very grateful for the opportunity of speaking to you today, and it's an excellent opportunity for me to revisit the All Party Parliamentary Group. We had a men's health one 7 years ago where I presented similar data to Martin's, and it's interesting when you look at men's health. In 1992, Kenneth Kalman, in his report on the state of the public health, had a chapter on men's health, and it was the first time that we'd had any kind of overarching statement around men's health within the government document. And as far as I can tell, it's the last time. I haven't found in any other government document a statement around men's health in the same kind of detail as was presented in that 92 report. For the Public Health Minister in 2001, I was asked to do a scoping study on men's health, and that was presented to her just before the election, and we again didn't see that go anywhere. But I'm not sure we've ever had another overarching scoping report on men's health, and that's going back to 2001. Since then, I have been busy. We did the state of men's health across Europe, and I led the academic team working with the European Commission on the state of men's health in Europe report for the European Commission. And I was also part of the team that wrote the World Health Organization report. The vision is evolving. We're learning more all the time around what constitutes men's health. In the first report, it was more about mortality, morbidity. As we go on, we realize it's about social determinants of health, the intersectional factors, and it's all about how men and women, the relationships between men and women. It's all about understanding how society works. And if we don't understand how society works in relation to men and women, we find it very difficult to make any kind of strategic direction. On the same time, we were also doing an awful lot of work in Leeds. We had work with the rhinos, we had work with the public, we had the Men's Health Week initiatives that drew in politicians and the local council. We had high profile events. And it was, I think, partly because of that the Joint Strategic Needs Assessment turned its attention, its lens onto the male population, and recognised, as we had been seeing over the years, and actually was stated in the 92 report, that there was a problem, and it should be an area for development. And they also had this understanding that they're spending an enormous amount of money, as the government is. The country is spending an enormous amount of money on healthcare and providing services, and is it being spent wisely? And if you're just throwing money at a problem without thinking about strategically whether it's worthwhile or whether it's going to work, then are you wasting it? So we had in 2016 the launch of the State of Mental Health in Leeds report. Leeds, third biggest city in the UK, first time any city had actually tried to look at what was going on with its male population, and it's the last city to have done that work. We still don't have any other city that's done a comprehensive overarching review of the health of its population. And that report shocked a lot of people. They just weren't aware. They knew bits, and I think this is what comes out from the comment in the Lords, was we're looking at this bit, 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 but no one has responsibility to look at it whole. No one shares or has the job of standing back and saying, right, well, have you not noticed all the links that are occurring? You're reinventing the wheel each time you look at these different sections. Standing back and looking strategically at it, you can see that you can make bigger steps forward, especially when you think a lot of men's problems are integrated. They're linked together with other problems. So if you're just looking at one, alcohol, and then smoking, without thinking actually they're both the same problem and we have to tackle them together. One of the things we said from that report was we needed a state of women's health report. And ironically, I think that's what's going to happen with the state of the women's health strategy. One of their findings will be that they need a men's health strategy, because as we found, you can't look at one without the other. And now we have, and I was fortunate enough to be asked to lead that state of women's health report, and the learning that occurred pulling that together as an expert in men's health, especially as I was working closely with the Women's Lives Leeds and some phenomenal colleagues across women's lives, women's health in Leeds. we've now got a really strong bond between the men's health and women's health. There is no competition. In fact, the lead, one of the lead workers now in men's health is working with the women's health on the women and girls safety issues. But when you looked at the men's report, it was exactly the same as what you saw from Martin's data. All the key cancers, key causes of death stand out as being predominantly male in terms of premature death. The one that really stands out for Leeds was the suicide, which was nearly 5 times as more men are dying from suicide. You see there again esophageal cancer, 3 times more men dying of road traffic accidents. But it's not just about the male mortality and morbidity. And this is, I think, a very important feature. This is population growth. And what a lot of people don't realize is the biggest growth within the population is older men. And we have got to be thinking about how we strategically keep men better, more fit as they go into those years. Otherwise, they're going to be living a long time with chronic illness.
Absolutely.
And this increase, this 36% increase in male up to 2039 means that there's going to be more males over the age of that population size than the current female population. And we are not geared up for older men. Most of the services are geared up for older women because that has predominantly been the population in the older and older age groups. And so we have to be thinking strategically about how we support these older men, especially now with dementia being the principal cause of death in women. More men over the age of 75 are the carers within a household. And so we've got to be thinking, if nothing else, about how we keep men well to be better carers. And we have to look after them as carers as well. The social determinants, when we look at the social determinants, we realize boys are not doing as well at school, and many men are leaving school without any qualifications. So one of the things we know drives development within populations is qualifications. We know that 68% more men were being identified as unemployed, more men claiming benefits, where more men were living in social housing, more likely to be housed in high-rise flats. I'll come on to that in a second. And also, we've got a significant proportion of the male population are single. And that leads to all sorts of issues around social isolation, social exclusion, even to the point where we had over 2,000 lone fathers. And this high-rise flat is very important because one of the things that we did when we looked at housing was we found that men are not seen as vulnerable. And so if any man needed social housing, he was put into the least desirable, but only available. So some of these blocks of flats, we had 85% male residents. And these are often young, single, low self-esteem, depression, social isolation, drug issues. And so now initiatives are going in there, the high-rise initiative, to try and support these men, to try and pull them out of these settings. And when we spoke to the commissioners, a really telling statement from one of them, these men are mostly invisible unless they are a nuisance. They don't flag up on anyone's system. No one has them as part of their agenda. No one's looking at men and saying, oh, right, what's happening to the men in this setting? And when we did a policy analysis, part of that work, gender is not well represented theme in the citywide strategies generally. And the only mention men specifically across all the citywide strategies were within the area of being perpetrators of domestic abuse. So we have 350,000 men in the city, and the only thing that the city at that time was looking at was them as potential perpetrators of domestic abuse. Now, the Office for Health Improvement and Disparities says that they are going to even up, level up the health issues. And they actually identify men as in the most deprived areas as nearly 10 years fewer lives than the least deprived, which is Martin also has said. And they need to prevent health conditions before they develop. How are they going to do that without knowing the men or where the men are? I mean, a key observation from our study was that they were doing comprehensive locality maps of deprivation, but they rarely offered sex-specific data. So you had this blanket population-wide, but they didn't actually note where the men were. So those men in those housing wasn't seen, and lots of issues. But it has made a difference. Now, Ian Cameron, the Director of Public Health, focused his entire annual report onto sex and gender issues. And for women, he looked at mental health, and he looked at alcohol. For men, he mentioned the drug and alcohol, and also the suicide. But a very telling statement at the end, where he notes a number of public health issues causing the health of men to get worse. Reversing these worrying trends needs to be a priority. And we have to base those actions on a greater understanding of the underlying gender issues. Now, at the moment, the country is relying on a 1992 assessment, and it just seems a little bit old to be doing that. I'm going to take obesity as an example of where we need to be thinking about gender. 68% of adult men are overweight or obese. Men tend to put on the fat around their midriff, visceral fat. That tends to lead to higher levels of hypertension, hyperlipidemia, diabetes, fat-related cancers, so all the ones that we've just been talking about, the hypertension that Martin's just been talking about, but who's looking at men specifically in relation to obesity? Another interesting feature about men and obesity, in the 16 to 24 age range, 55% of the male population has a normal weight. And it rapidly drops between then and 25 to 34 to 39%. And it just keeps going down. So by the age of 45, only a fifth of the male population has normal weight. In women, it's 33%. It's a very different profile. They have a much slower decline into overweight and obesity. And certainly for women, the morbidly obese is desperately difficult for them, as the State of Women's Health report showed. And we've got to think about how women manage their weight, etc. But for men, who is looking at these younger men? It's certainly not the health service, because the health service, when you looked at the people who did not have weight recorded, over a quarter of the men did not have any weight recorded in their records. Whereas for women, it's part of their natural process of medicalization. Their weight is important. Someone's looking at their weight as an issue, and so therefore it's being taken into consideration. When we looked at weight management within these, we recognized that there were perhaps similar numbers of men and women who were overweight or obese, but when we looked at who was being treated, the predominant number were female. And it was because the commissioning wasn't based on sex. So if they say 5,000 people have to be part of your weight management, the easy 5,000 are the women, because the women go to weight management classes, or they ask for weight management, and the men are not asking for it. But when the men got there, they were more likely to lose weight. Another interesting graph, this is overweight. 52% of men who are overweight see themselves as being about the right weight. 31% of women. Even 13% of obese men see themselves as being about the right weight. The meaning of weight is different. And so we've got to be thinking about how we gender weight loss services. Leeds Integrated Market Position Statement has been one of the most significant developments. This drives all the purchasing of services across the city. And it gives the marker to anyone who's putting into a tender what we are looking at. And what we have got within that now, we have, where they talk of children before, they now have to recognize that children is boys and girls. Where they talk of adults, they now have to recognize that's males and females. And so when they're looking at how they're developing a service, they have to think, this is not just for women, this is for men and for women. And the specific commissioning influenced by the Men's Health Report has seen street activity. Mental Healthy Leeds is now specifically looking at how it reaches men. Your Space, public mental health services, 1U, the drugs and alcohol, the preventive cancer contracts. We know that there's issues around bowel cancer and how different it is between men and women. So how are we reaching into the male population? How are we reaching into the female population to get the messaging across? Suicide prevention, phenomenal work around suicide prevention in Leeds. If you want to look at that, that is tremendous. Integrated healthy living, which incorporates the obesity and community health development. And Men's Health Unlocked It has been funded by the National Lottery, and we are just seeking some more funds. They're doing tremendous work. They're now linked up with 70 organisations across the city. They've been giving iPads to tablets to men who are in those high-rise flats, the socially isolated. They're working out how to give mental health support. And also they're working with the Women's Lives Leeds in terms of supporting them in relation to their work around domestic violence. A simple fact that this was one of the final statements I put in our report, a simple fact that was worth remembering is that improving the physical and emotional well-being of men and boys will have benefits that spread out across the city and will make it happier, healthier and wealthier. It's a simple message. If you have men ignored, then and their mental health issues are not taken care of, their physical health are not taken care of, it's a nightmare. Any man who is struggling with their mental health, it is a nightmare to try and work out. We've got to work more proactively with them. So why do we need a mental health strategy? I think there is fundamentally a lack of coordinated service provision for key mental health issues. Around weight loss, mental health services, cancer risk, preventive care, health promotion, you name it. We've just not got a strategic view of it. And that is driven by a general invisibility of mental health as an issue at the political level. There is no driver. Leeds had drivers from me and from all the Leeds Mental Health Network and all the others locally, but there wasn't anything from above telling them that they had to do this work. And now they've done it, it's working amazingly. And I think there's a development of small-scale initiatives, ad hoc, which is great, and they're making fantastic initiatives with men, the sheds and all sorts, but we have to look at the entire population. Cancer screening is an entire population event. You can't just rely on a little group of men somewhere or another group here, you've got to be thinking strategically about how you get all the services to be focusing in on managing mental health better. And finally, we can't afford not to. It's expensive having a poorly man, and as an old colleague of mine used to say, keep them standing up. When they're laying down horizontal in a hospital bed, they're extremely expensive. Thank you very much.